no disclosures related to the presentation. This is the topic we're going to be discussing about. And actually, to be honest with you, fluorescent angiography continues to evolve in all disciplines, and it has been recognized and more widely applied in congenital heart disease, as you can imagine, in newborns and early pediatric patients. There is a significant role to identify vascular structures as they are doing these complex congenital cases. I think we remain with the potential to apply it widely in adult cardiac surgery. And to be honest with you, this is something that we sort of explore, and it was described 2 decades ago. So cardiac surgeons were earlier adopters of the game. I guess at the time it was bulky devices, and talking with a couple of the surgeons who explored the application of this, it was the bulky devices and the complexity to apply it in the operating room, and so that sort of made us shy away from that. But you can see here the value that was described. This is 2003. This is from UK, a group of over 80 patients, and so where you see arterial composite grafts, complex grafts, including jumping graft on the picture there on the lower left, where they were able to identify properly the patency of the graft and whether the graft was open or not, eventually leading to the revision of 4 grafts over 80 patients, over 200. So very minimum, I guess, surgeons, cardiac surgeons, have been sort of, confident about the work that we do, and so. But it's true that eventually we understand there is a percentage of these grafts that eventually clog down and close down before the patient leaves the operating room, and then or before the patient leaves the hospital for the index admission. Eventually, subsequent studies compare the application of this technology along with the ultrasound to measure the flows in the graft, and there is other factors that come into play that had not been addressed at the time, which is more dynamic factors as the physiologic perfusion and the impact of doing these grafts on patients that already have an extensive network, arterial network in the myocardium, and there is other factors that compromise the perfusion of the heart, such as diffuse disease, more frequently seen in diabetic patients, or the sort of the hypertrophy of the myocardium. These patients oftentimes have valve disease, and so. So as we jump into understanding how we could apply the new devices and this technology to current practice, actually it came handy being an active center with heart transplantation that would allow us to take these hearts out, oftentimes disease, that we had worked up these patients head to toe, and we knew whether they had heart disease, coronary disease, or valve disease, and no, and start applying the ICG to understand, okay, if we apply it on the root, which are the doses we need to apply, how we interpret which is a mode that is going to be not just contrast directly, which is a mode that is going to allow us to get the better images and start getting a sense of how to interpret these images. And René, the support with Dr. Rosenthal and so has been critical for us to get into the field. So now we got a better understanding on how we get into there with a more objective assessment, and we're still in the process of the technology fully understanding and standardizing the images that we get, as I'm going to show you, and different applications in patients with coronary disease. So we know the maximum dose is 2 milligrams per kilogram. We definitely try to avoid it in the minimum patients that have allergy to iodine. And we know that once that we prepare the solution, we need to use it within the 6 hours because it's aqueous and stable. We have not seen any patient with anaphylaxis so far, and hopefully we'll continue that way. It's been described in a very minimum set of patients. And so you know that during coronary disease and the subsequent surgery, coronary bypass surgery, the patient goes through a phase that we are taking down the grafts, then we arrest the heart, we have perfusion down the root, selective perfusion to the heart with the protective solution, the cardioplegia solution, independent of the rest of the perfusion to the body. And so there is nuances and particular conditions of these patients that come into play as we get into all this. So we understood how to apply, how to interpret the images, the early phase of perfusion within the first 30 seconds, the peak phase in the 30 to 60 seconds, and how it would wash out within the 3 minutes. And so this is what we were presented as we got into our initial experience with the heart that was beating, trying to understand how we would apply it. And so then this is the administration, and it gets sucked into the pump. The solution that goes IV goes into the pump, as you see, through the venous cannula, to then return to the arterial cannula, and then down the route and into the coronary arteries to help us understand where are the blockages, as you see there, for example, in the mid-left anterior descending artery, and the distribution in the muscle of the heart. Then when we look at the lateral wall, we look at the inferior wall, the images remain pretty patent, and we saw that the contrast might play a role to identify the anatomy, but not quite so much maybe to have a better sense of the physiologic perfusion and the distribution in the muscle as the vessels got smaller and smaller. There is also a role to understand, to identify the arterial grafts and the venous grafts as we do, and we use the handheld device, the SPICE device for now, as opposed to what we do when you do the laparoscopic surgeries and you're looking at the screen and you have the opportunity to overlay. So that comes a little bit as maybe the interface. There is opportunity to and will hopefully improve moving forward, in which we may find ourselves working on the heart and looking away from the heart, working with a millimeter of precision on the heart and looking away from the heart into a screen that is. So I think that is one of the things that might have limited enthusiasm and adoption of and hopefully will have better interface as technology evolves to be looking at the heart and have superposition of the images of what we are doing. We had the opportunity and learned how to assess the graft and the myocardial perfusion, as I was alluding to, and a little bit of what we were saying. And at the end of doing the cardiopulmonary support, and we have connected the graft, at the time of reperfusion, we have the opportunity, once that the patient is stable hemodynamically, to administer again ICG and then get a result of the graph that we see. And you see that same patient now with the revascularization and the improved perfusion to the apex of the heart, the lateral wall, the inferior wall of the heart, and you can see 2 or 3 grafts that were done there. Sorry, that's a hand of the surgeon. And René, you should have moved the camera. But you see the graphs there with the and the perfusion to the muscle of the heart there. Let's see if we can play this one. Okay, can you play this? Okay, there we go. This is again another one in which we are seeing the lesion in the middle AD actually, and you see the limited perfusion to the heart. Then with overlay, trying to understand a little bit better the distribution of blood. And that was actually a myocardial bridge, a segment of myocardium that was actually some fibers of myocardium that were compressing on the artery of the heart. That needed to be open before applying the graft. That's a Lima, a left internal mammary artery, applied to the left anterior descending artery of the heart. And see here you can see an additional vein graft to the diagonal there, the graft, the Lima to LAD there, left anterior descending artery, and the vein graft to actually the diagonal there branch. And you see the improved perfusion, and then with CSF trying to get a better understanding of what I was referring to, the functional effect of all this and how that eventually improves as we do the coronary bypass grafting. This is another application that we adopted. Patients that have a longer intramyocardial segments of the coronary arteries. This is a particular case, if you can play it, in which we have a patient that had a young patient with ongoing recurrent angina. We do the coronary angiogram catheterization beforehand, before the operation, and we are missing an extensive artery, the left anterior descending. They call it the widowmaker, because it can cause, when that gets in trouble, patients tend not to survive. So extensive workup, including 3D reconstruction of the CT scans of the thorax and the heart, to identify the missing portion that on the coronary artery there, as you see, the left anterior descending coronary artery. This was compromising actually the heart function with, in the echocardiogram, the contractility of the left ventricle estimated at 30-35%. So recurrent chest pain, limitations in terms of shortness of breath, really affecting the quality of life of this young patient. We were able to identify the area of the bridge, but not only the area of the bridge, but where the artery is sitting. Because you know, the wall of the right side of the right ventricle, it may be about 5 millimeters, and with this artery that was there buried about 8-10 millimeters in the septum, you are a couple of millimeters to the right or to the left, and you fall inside the heart. And that's a significant problem, heart problem to fix. We didn't want to get there. So you see here the extensive dissection of all these myocardial fibers to expose and decompress that left anterior descending coronary artery. And just by releasing all that, we are able to restore and improve the blood flow to the septum of the heart, to the left ventricle of the heart through the collateral diagonal branches, and to the septum of the heart through the septal perforators. No need in this case for a coronary bypass grafting or anything. All that this patient needed was for us to free up the muscle of the heart that was compressing on every heartbeat, literally, that left anterior descending coronary artery. And here the ICG played a critical role, as we saw in those images, to identify all the trajectory of the artery and do an extensive but safe dissection, digging out the muscle of the heart and avoiding. As you can see there, we move from the scalpel 2-3 millimeters and dig underneath on the right side of the heart, and that would be to the left of the screen, and we would fall into the right ventricle. And that's a bad problem to fix. A little bit of hemostatic stitches to the muscle of the heart. And this is the end result there with an extensive unroofing of that of the main artery of the heart, the left anterior descending, as you see, and the value of ICG to have identified all this area where we needed to work. And the good thing, the heart looks stronger already, beating again, coming off pump. And as we did the assessment with further diagnostic studies, that heart had improved back to normal, complete normal contractility, ejection fraction above 55%, symptoms resolved, of course, no more heart failure, no more fluid retention, no more chest pain, and a critical role of the ICG to aid us in the resolution, safe resolution of this patient. And this is a coronary angiogram that the patient agreed to have, showing the much improved blood flow down the coronary artery, the left anterior descending coronary artery. Another considerations and expanding application is in less invasive approaches for coronary bypass surgery. And in this case, the robotic technology that is being more and more approached. Initially, in the past 10 years, there has been an increasing adoption for valve surgery, but in most recent times for coronary revascularization, 1-2 specific bypasses. And it's assisted because anastomosis, a couple of millimeters long anastomosis, it's still done, under direct vision. This is about 2-inch incision in the left side of the chest, and you are looking down where you see the connection of the left internal mammary artery to the left anterior descending, and now with overlay you can see the perfusion of the blood, and as we said, it's going to be, you see the graft there and the anastomosis, and you see the perfusion of the muscle of the heart, and it's going to be washing out and disappearing within 2-3 minutes. And this is another case of robotic-assisted mid-CABG, 60-year-old female patient with intermittent chest pain, and so on the workup she had occlusion of the left anterior coronary artery. Oops. If you can play this, please. And let me see if we play it. Can you play it? It was another study with similar workup and the diagnostic procedures, but there is a true value in these less invasive approaches to really help us identify in cases we need to take down, and the graft, the left internal mammary artery, can be buried under the endothoracic fascia, not easily identified. Now, having to grab and go there with the robotic arms, and it's very useful to identify the location and help us identify all the collateral branches to free up the artery and bring it down. Then with a 1-2 inch incision on the side, we are able to perform the anastomosis and the direct vision, and the application of ICG again, like the image we saw before, allows us to have certainty that that work is done, has improved the perfusion, and it's effective. So, coronary surgery has for the longest time been one of the few procedures that we finish, we get done, we are looking at an outcome that we expect, and we measure in terms of 15, 20 years down the road that is going to affect significantly the quality and the life expectancy of the patients, and the patient rolls out of the OR without a test to quantify and to certify the quality of the work we have done. So we are very excited with progressive adoption of all this technology, and these are some of the applications where we've been using it. Small tips, but that we share with our anesthesiologists about flushing always with saline or ringer to avoid or saline to avoid the precipitation of the dye and getting false images, and the importance of understanding truly the anatomy and the physiology that for us surgeons of each individual patient based on the preoperative assessment, and then so we can translate that to interpret the baseline images with ICG and the subsequent images after we do the grafts, right? Thank you.